I work in the Women's and Children's Hospital in Singapore. I've been working there since we moved in 1997. And in Singapore, the general pediatric surgeons do the pediatric urology. This particular picture was taken a few gray hairs ago, and I thank the organizers for the invitation to speak. I sort of wish I had a conflict of interest, but I don't. I thank the Department of Pediatric Surgery for their help, especially Dr. Yap and Dr. Clarissa Gubani for their assistance. Dr. Gubani has just looked at our numbers and done a presentation on hydronephrosis. And I'm very happy to be with you, but I wish I could be with you in person. So because this is a very big topic, I thought I would limit myself to three main focus areas: management of the pregnancy, management and investigations at birth, and indications for surgery. But as all good speakers, we have a few subtopics as well. So in Singapore, the majority of hydronephrosis cases are antenatally diagnosed. When a woman misses her period, she goes for a dating scan. And this is usually at 6 to 10 weeks of pregnancy. Then there's a Down syndrome scan at the 11 to 14 weeks and a fetal abnormality scan at 18 to 22 weeks. Usually this is done in KK as 20 weeks. And at that time, you can see the hydronephrosis very well. In all of these cases, there are several follow-up scans, and in particular, if the patient comes from the private sector where 60% of the deliveries are done, they have a number of fetal abnormality and follow-ups, fetal growth scans. The mother will have the exact same management of the pregnancy unless there is oligohydramnios. So if there is oligohydramnios or bilateral ureteric dilatation, they also have to look for bladder wall thickness, other associated malformations, and the gender. So I believe gender assignment is quite a challenge, but this is one area where gender knowledge is important to anticipate delivery of a patient, a male patient with posterior urethral valves. So this is roughly what they see, and it looks a bit like gray snowstorm, but these are what the antenatal, the obstetricians are looking for in antenatal scans. So when they see a dilated kidney, they immediately look for ureters, and they look for the bladder, and they look for the gender. So in 1996, the National Center for Health Statistics in the US found that this is up to 2% of patients who are diagnosed this way. And the cases drop off repeatedly when you see how many are there postpartum, how many are then have abnormal investigations. And initially there was great enthusiasm for surgery, but this has dropped off a bit as we have gone along. So at birth, we do an ultrasound. We recommend doing an ultrasound in the first week of life, but the first few days the baby is relatively dehydrated, so we don't recommend doing it too early. In MCU, we don't do routine MCU. We used to, but now we follow international guidelines and only do it when necessary, because the MCU is uniformly hated by the parents. There are some associated problems, and we don't recommend doing this routinely. A renogram is usually done after 6 weeks. It has to be timed, and it has to be a well-hydrated child with good renal function, and you should consider urethral catheterization. The renogram people are very, very reluctant to catheterize a child, and you will see what happens. So we follow various, there's a AUA as well as ESPU guidelines in order to limit the use of the BCUG only to a certain number of patients. So the patients with high-grade hydronephrosis, bilateral duplex kidneys, ureterocele, ureteric dilatation, or abnormal bladders, where a likelihood of reflux is much higher, then they use an MCU. An MCU is, or BCUG is not the physiological investigation. And we also try to use a grading system. The grading system is only as good as the radiographer doing the ultrasound for you. But we found that we have followed now the UTD classification system. Earlier we used to do the SFU grading system, but it depends really whether the radiologists know what they're looking at. And so you want to identify those patients who are at risk of deterioration. So in Great Ormond Street, Gita Dillon did a study in 1998, and she found during observational studies that those with a renal transverse renal pelvis diameter of more than 20 millimeter were at risk for renal deterioration. In 1919, this is many, many years ago, Frank Hillman Sr. did a fantastically elegant study where he ligated the upper ureter of baby rats. And we found that the duration of obstruction is proportional to the severity and reversibility of obstruction. So if he undoes the ligation at 2 weeks, they may return to normal function. At 3 weeks, they may return to half normal function. More than 3 weeks, the animal survival required partial or complete nephrectomy. This is a very, very important study that was published a number of times, but shows us that this functional obstruction needs to be relieved. And so the Society of Fetal Urology have suggested grading of the, based on the ultrasound. As I said, it depends on who's doing the ultrasound, and this is really the study that is now being replaced by another similar study. But grade 3 and 4, suffice it to say, where there is significant dilatation and intrarenal dilatation as well, are considered with deterioration of the kidney. So we have looked at this in Singapore General Hospital, and before moving to the Children's Hospital, we operated on 41% of the patients where we thought we had diagnosed PUJ obstruction. I think now we operate on a little bit less. MCU only in certain selected cases, and this is where you have to get the radiologist to look for bilateral dilated ureters, to look for the bladder and the outlet to see whether there's any other reason for you to do an MCU. So initially we used to do MCU for all patients. Now we do them only in some cases and only if we trust the radiologist. A DTPA or MAG3 scan is only done with relatively renal maturity, so at least 6 weeks old child and a well-hydrated child. You may wish to insert a catheter, and F + 0 or F - 15 refers to the timing of the furosemide. So F + 0 is the furosemide is given at a certain dosage per kilo at the time of the injection of the isotope. And so these are reported by the machine itself. So here you can see the huge bladder effect that happens in an obstructed renogram curve with relatively preserved renal function. So these are some pictures that I took of Steve Koff. I'm not sure if he's aware of this. He has actually retired now. But he says we rely a lot on the T-half done on the renogram, but he says in these less than 2-year-old kidney, 2-year-old kids, the T-half appears to be very, very inaccurate in determining obstruction, but we still rely on these as an indication for surgery. Sorry. So if you don't have isotope renogram, you can try to do other things. You can do a purely ultrasound-based, or you can do MR urograms, which can give you similar images. But the MR urogram, they have said, it provides excellent anatomical and functional information. But again, in our setting, this is much more expensive and requires a general anesthetic. So in order of follow-up, you need to know what other diagnosis you are considering, how frequently you are going to follow up, or how soon is the baby going to deteriorate, and are you going to use antibiotics? We often use antibiotics in the first year of life, but actually in the kidney, the urine is supposed to be sterile. And how often are you going to do imaging studies for these patients? So this is Tony Corey and Gordon McClory taken in San Francisco in 2001, just after, or was it 2002? Just after September 11. And so Gordon McClory has monitored these patients on serial ultrasound examination. Gordon has since passed away, and I think Tony Corey works in in California, I think. So they use a frequency of ultrasound to monitor the patients, which we have also continued to do. So initial enthusiasm, there was a lot, you know, here we have a new procedure, it's got good outcome, less risky, let's do pyeloplasties on the whole lot of them, until the UK surgeons said, well, hang on a minute, you know, do we really need to operate on all of them? And so I think now less and less are being operated on, and more patients are being observed. So surgical interventions, when do you operate on these patients? Usually we don't do these as neonates, we do these at least at 6 months of age. And we try to operate on those patients who have higher chance of deteriorating. The risk of surgery in my setting is minimal, but it may not be so everywhere. And so there is a recent paper from Canada which tells of doing a score based on differential renal function, drainage curve pattern, and SFU grading. And based on this score, they operate on the patients. This is similar to an earlier study done in Turkey, where they do a transverse renal pelvis diameter at birth more than 20 millimeter and a deterioration of split renal function as indications for surgery. So how are you going to do this surgery? Are you going to do it open, or are you going to do this keyhole? Are you going to do this robotic? Most of us agree the Anderson-Hines pyeloplasty has stood the test of time. This is an image from a left open Anderson-Heinz pyeloplasty, which shows a serpiginous configuration of the ureter at the UPJ. And this is causing a functional obstruction in an otherwise normal ureter. So it's only Craig Peters, this is from when he was in Boston, he's no longer there. So he can show that this has advantages using the robot. We had the robot for 2 years in KK, and our funding issues and the way we set up it was like a non-starter to add on $6,000 to $8,000 per patient without any proof of increased benefit to the patient. So do you need a robot? Well, maybe you do if you need to stitch very carefully. I'm not so happy with the stitching when I do it laparoscopically, but that's perhaps because I'm a lousy stitcher, I don't know. So it depends on your budget and on the patient's budget. But when you study your results, when you're off the learning curve, you need to use your own results. You can't use Craig Peters' results because he's working in a different setting. So remember that everybody will report only excellent results. Textbooks of operative surgery never bleed, and you never have any complications when you look at videos anyway. And so Benny Ure says that this is feasible irrespective of age. Craig Peters reports this with a robot and can also be done retroperitoneally. We are increasingly using retroperitoneal surgery, and we are amazed that patients are sitting up immediately after surgery without any pain. So after pyeloplasty, we generally do serial ultrasounds and we do intermittent MAG3 or renogram scans. If you haven't done a dismembered reduction pyeloplasty, sometimes you have a baggy system and you have to work with your isotope person, your imaging person, to get accurate studies. So some of these patients, if they have less than 30% differential function, will have contralateral renal hypertrophy, and they are at risk of hyperfiltration later on in life. And therefore, these patients are referred to the nephrologist as well. So Koyanagi in Kyoto, Japan, in Hokkaido in Japan, has also looked at this and has increasingly operated on fewer and fewer patients. And if you don't have a renogram, you can also do this. So this is a recent paper published from Canada, from Frontiers in Paediatrics. It isn't a great paper, but they have used various measures on ultrasound to look to see whether they can identify the patients at risk for deterioration. And so this is what they have done, and in addition to what you do, you also do an absolute percentage difference in renal length. Now, we have to be reminded that the ultrasound is an operator-dependent procedure or investigation, and therefore you need somebody who is interested in ultrasound to do this. So in summary, when we talk about hydronephrosis, challenges in diagnosis and management, in Singapore, the vast majority are antenatally diagnosed, and the pregnancy will continue normally. At birth, we do an ultrasound in the first week, MCU only in selected patients, and then a DTPA or a MAG3 scan only at 6 weeks of age. Surgery is reserved for those patients who are at risk of deterioration. So grade 3, 4 SFU grading, obstructed renogram curve and decreased differential function. Normally these patients will also have more than 2 centimeters transverse renal diameter in dilatation. Thank you for your attention, thank you for the invitation, and really I wish I could travel and see everybody. Thank you.
Okay.
So there's a question from the audience.
My question is that what is your minimum criteria for renal scan in case of congenital hydronephrosis? Do you subject every child to following them to renal scan, or do you have any specific criteria? I know that with passage of time, when you see time to patients more and more, you sometimes tend to deviate from the normal recommendations. So what is your minimum criteria to subject
Thank you very much for your question. You can hear me?
Yeah.
Yes.
Yes. Now, I think there are very many variables. Most of our patients are referred from the obstetricians or from the pediatric nephrologists, and they have already done all the workup. Now, the problem comes when we have patients who are referred from outside or come from for second or third or fourth opinions, and really have very good kidneys without the 2 centimeter transverse renal pelvis diameter. And so we do renogram scans on nearly all of our patients because they have been extensively investigated already. And the parents have already been to see Dr. Google and getting all their information and whatever, and they expect and they demand a certain amount of investigations from you. Saying that you will have a renal ultrasound, well, they all have renal ultrasounds and they have serial renal ultrasounds. And so it's important for us to do a renogram study, and it's important that we train our radiographers or whoever is doing the nuclear medicine in your unit to do a proper, well-tempered renogram. So we do it on a whole lot of them. Ideally, it should be a screening study for those with increase in differential function or increase in differential length.
What is your criteria?
No, not 3, 2.
Oh, sorry, 2. Okay, 2. If it is less than 2, if you not ask for renal scan.
Yeah, so if it's less than 2, they have a slightly lesser chance of deterioration, but they can still deteriorate. So it also depends on the hydration of the child, the wishes of the parents, and the previous done investigations. Very often the parents will demand for it, and we will do it anyway.
Okay. Suppose you have a scan a patient and at this much of dilatation, and what is your next criteria to repeat the renal scan in these patients?
So if there is a scan with a deterioration in renal function, then we will do a follow-up renal ultrasound and tell the parents treat your child as per normal, but it looks as if your child is going for surgery. So get them to prepare themselves, get them to talk to Dr. Google or talk to their friends or whatever, and decide what they want for surgery. But a lot of these patients with increased renal pelvis diameter, increase in length and thinning of the cortex of the kidney will also have a prolonged T-half, which we know is inaccurate anyway. and will also have a decrease in differential function. The longer you leave it, the more deterioration you're going to see in renal function. And so we operate on quite a few of these patients.
Okay.
Okay, thank you very much.